Hello and welcome to Evidence-Based Tools for Palliative Care brought to you by the NHPCO Palliative Care Council. My name is Bernice Burkhardt. I am the Chief Medical Officer for Home Health Foundation in Massachusetts.
My name is Rory Farrand. I'm the National Director for the Palliative Division for VITAS Healthcare.
I'm Christine Kandawal. I'm a palliative care and hospice physician for Transitions Life Care and serve as a VP of Education and Strategic Outreach in Raleigh, North Carolina.
Hi, I'm Tiffany Hughes. I'm a nurse practitioner with Palliacare Incorporated, which is a rural community-based palliative care company in Northeast Texas.
Hi, and I'm Bob Parker. I'm Chief Clinical Officer, Chief Compliance Officer for Intrepid USA, a home health hospice private duty organization.
And hello, I'm Lisa Vandewell. I'm the Executive Director of the Hospice and Palliative Care Program at Spectrum Health in Grand Rapids, Michigan.
And you can tell here we have no disclosures to declare. Upon completing this session, participants will be expected to be able to describe a core set of evidence-based screening and assessment tools. And this will be for teams for caring for patients who are living with serious illness. You should be able to also, at the end of this session, identify tools and resources which you can use to screen for, assess, document, and manage the palliative needs of your patients. Ultimately, you can also identify tools and resources to improve practice efficiency for primary care providers in managing the needs of palliative care patients.
We wanted to explain a little bit about who we are as the NHPCO Palliative Care Council. We provide a few things to support all of our teams across the country practicing in different sites. More specifically, we are a specific work group of the Greater Palliative Care Council formed to identify a core set of evidence-based screening and assessment tools to provide today for recommendations for use. You can see we do a lot of other participation for each other. We provide setting direction of NHPCO efforts to support provider members as they expand and continue their efforts in provision of palliative care. We assist with the development of resources and tools related to various models of palliative care delivery. We help get involved and informed with public policy. We offer recommendations regarding presenters and content of palliative care education. And we advise, again, NHPCO regarding palliative care membership and related member offerings. Next slide. So why is this being explored? Why did we find this important? We think it's important that every clinician caring for our patients with serious illness conduct regular screening for other comorbidities, which really may affect symptom treatments, their quality of life, and prognoses. A wide variety of assessment tools exist, and there have been used in palliative care for the assessment of symptoms, quality of life, and helping with prognostication as well. There is a wide variety of assessment tools, and it's used by a variety of different providers, including our palliative care colleagues, but also a lot of our primary care providers who are actually in the best position to screen our patients for symptom burden and to continue conversations for their care priorities. So we felt this was important to be able to take a look at the assessment tools available. Next slide, please. So we wanted to be sure that we have an understanding of a little bit of background of why this is important, why this all matters. We all aware and recognize we practice in different care sites as palliative care hospice providers, but we are all honestly recognizing and having conversations with our stakeholders about different information they are seeking from us. For example, what is the trending data for risk stratification and determining the need for hospice care for our patients? What about standardized tools for measuring clinical quality outcomes? We also want to think about the ease of burden for clinicians and our seriously ill patients and individuals with these diseases. We obviously want to provide each other with the most up-to-date evidence-based practices and support each other of that knowledge. We want to individualize care plans and patient engagement, really thinking about goal setting. It's important to be part of that conversations to inform the EMR. A lot of us are at the table with our stakeholders, again, building and optimizing EMRs, and we get to add information about what kind of data is important. What are the interventions that we feel is important in regards to CWAPI, to get involved with call to actions of partnerships and inform policy setting. Next slide, please. So we hope with all the information we look at and share today, we will review the tools which we feel can address the following needs for all of our patients. We want to look at really the 5 main important items and issues for our patients. Well, number 1 is symptoms. Number 2, functional status. We want to be note the tools are for disease progression. We want to be aware of tools for cognitive status. And finally, being aware of the screening tools for anxiety and depression. Next slide, please. So how can tools help improve care for our patients? Well, we provide an extensive review of the available tools to ensure palliative care providers, again, are abiding by the most evidence base of these tools that they can provide for us. So for example, a lot of these tools, we know there's a presence of research that supports the validity of the tool. We wanted to see there was validity across care sites, because again, we all are practicing in different care sites for our patients. What about the source of information, the assessments? Can caregivers give the assessment information? We wanted to recognize that some of these tools can have the ability to be integrated in the EHR. We find that's an important feature for some of these tools. How about the ability of these tools to be accessed through a patient portal? A lot of us are working in that kind of environment where our patients have access to their information. Next slide, please. We wanted to be sure that we were aware of tools that provided and added to estimated time in regards to how long it takes to complete. We wanted to minimize that burden. We were hoping that these tools could provide information, again, informing of risk stratification. And finally, a lot of our partners, collaborations, and stakeholders are looking at more value-based care. So we wanted to be able to have a requirement by a value-based contract or regulation with our tools. Next slide.
So some of these tools are going to be tools that are actually used in other care sites. And we are continuing to do our work and exploration of these tools used in other arenas of healthcare. One of the examples is the outcome assessment information set, as well as which is used in home care, and the minimum data set, which is used in skilled nursing facilities. Both of these sets of tools actually look at different statuses of the patient. They look at the physical status and the functional status as well. And when we are able to speak the same language with our partners who are a little bit further upstream by using the tools that they also use, then we can gain a better understanding of where our patients are and facilitate the access to earlier palliative care for these patients. One of the things that we look at is pain. And I think I lucked out because this is probably the one set of tools that most people use most, right? There are, of course, adult and pediatric pain scales that are available for use that have been validated, as well as one of the other ones, which is really more of an approach, the WILDA, and I'll go over that as well in a moment. As you can see from this grid, this is how we approached all of the different tools. We looked at the tests themselves, the screening tools. We looked at notes for who these tools were meant for. And ultimately, is there evidence-based to support the validity of the tool? And what is the source of information? For most cases, the patient is going to be our most reliable source. Again, in this particular set of tools, there are things for nonverbal patients or pediatric patients who are pre-verbal. So obviously those won't be provided directly by the patient. When we look at pediatric pain scales, we look at one of the most well-known, I think, is the Wong-Baker Faces Pain Rating Scale. The thing is that this is for children who are verbal, 3 or older, that can look at the picture and identify with the picture and say, yeah, this is what I feel like. So that is how that scale is supposed to be used. For children who are younger or perhaps nonverbal, there is the FLAC scale, which is face, legs, activity, cry, and consolability. There are points given for each of the factors, and then a total score that matches up to our standard, right, 1 to 10 pain scale. We also have other adult pain scales. The standard, again, that most people utilize is the 1 to 10 numeric rating pain scale. This is to be done by the patient. The patient themselves must be able to communicate and understand what's being asked of them, right? The least pain or no pain to the worst possible pain ever being at the 10. And we do care for nonverbal adults, and there is the CNPI, or checklist of non-pain indicators. If you look, it looks very similar to the FLAC in terms of looking at behaviors that manifest in pain. So you arrive at your scores that will match the 0 to 10 pain scale. And then the WILDA approach. Again, this is more of an approach to pain assessment. They focus on words, as well as looking at the intensity. So you can even incorporate another scale in here as far as intensity, right? You can use a numeric pain scale as well. And then does a deeper dive into looking at the broader aspects of pain, a more holistic, if you will, approach, looking at the location, duration, the frequency, any aggravating, alleviating factors, and what's affected, as well as any of the associated symptoms as well. And what's important here is that you have a set of tools that you, perhaps in your organization, have said, okay, these are the ones that we're going to get really good at, and then share those with your provider partners as well, so that they understand the tools that you are using to go ahead and assess where patients are, to be able to track how they change over time and how they may impact, again, the timing for access to palliative care. And now I will pass it on to Rory.
Thanks, Bernice. So one of the tools many of you are likely familiar with is the Palliative Performance Scale, or the PPS. The PPS is a valid, reliable functional assessment tool that was developed by the Victoria Hospice in 1996, and it's a modification of the Karnofsky Performance Scale. This tool provides a framework for measuring progressive decline in palliative patients across a variety of sites of care, as well as across specialties. It allows for a common framework or point of reference, which helps our clinical teams ensure that they're all speaking consistently regarding a patient's current level of function, and or to be able to track functional decline across time and measurement points. It is a valid and reliable tool, as seen by a study done by Ho and colleagues in 2008, which demonstrated strong inter and intra-rater reliability as well as validity. In case you're not familiar, to introduce you to the tool, this tool has 5 functional dimensions. The first is ambulation. The next is activity or evidence of disease. The next is the ability to complete self-care, food or fluid intake, and last, level of consciousness. When you score it, there are 11 levels of the PPS from 0% to 100%, broken into 10% increments. Every change of score by 10% marks a fairly significant decrease in physical function. So for example, a patient who has a score of 100% is fully ambulatory and healthy, whereas 0% indicates death. To score, you're going to begin at the left column and read downward until the appropriate ambulation level is reached. Then you're going to read across to the next column and downward again until the activity or evidence of disease is reached. Then these steps are repeated until all 5 columns are covered before assigning the actual PPS for that patient. Stronger performance indicators are on the left side and softer ones on the right. In determining a patient's PPS, then, we would first find the level that fits with their level of ambulation. And from there, we would work our way across, keeping in mind that the leftward indicators have more value than those on the right. To walk you through this, I've got a couple of examples. The first example is a patient who spends the majority of the day sitting or lying down due to fatigue from advanced disease and requires considerable assistance to walk even for short distances, but who otherwise is fully conscious with good intake. This patient would be scored at a PPS of 50. A second patient who has perhaps become paralyzed and is quadriplegic but requires total care would have a PPS of 30. Although this patient may be placed in a wheelchair and perhaps seem initially to be at 50%, the score is actually 30% because he or she would be otherwise totally bedbound due to the disease or complication if it were not for caregivers providing total care, including that lift and transfer, even if that patient has normal intake and full consciousness. Remember, it is important when using this tool to be aware that the scale is developed and validated based on the activity the patient can do independently. So as you familiarize yourself with this tool, you'll likely notice that some of the terms may appear to have similar meaning, with differences that become more readily apparent as you work your way horizontally across each row. That way you can find the best fit using all 5 columns. So in the ambulation section, the terms mainly sit or lie, mainly in bed, and totally bedbound are pretty similar, but the subtle differences are related to the items in the self-care column. So for example, a totally bedbound patient who is at 30%, they're there either because of profound weakness or paralysis, such that the patient not only can't get out of bed, but is unable to do any self-care. The difference there between sit or lie and bed is proportionate to the amount of time the patient is able to sit up versus how much time he or she needs to lie down. Reduced ambulation begins at a PPS level of 70 and continues into the 60% level. But by using the adjacent column, the reduction of ambulation is tied to the inability to carry out a normal job, work occupation, hobbies, or housework, things like that. The person is still able to walk and transfer on their own, but at a PPS of 60% needs some occasional assistance. In the activity and extent of disease column, some, significant, and extensive disease refers to physical and investigative evidence which shows degree of progression. So for example, in breast cancer, a local recurrence would imply some disease. 1 or 2 metastases in the lung or bone would imply significant disease, whereas multiple metastases in multiple organ sites, hypercalcemia, or other major complications would be considered extensive disease. That extent may also refer to progression of disease despite having any active treatments. The above extent of disease is also judged in context with an ability to maintain one's work and hobbies or activities. So for example, people who enjoy walking will gradually reduce the distance that they cover, although they may continue trying. And I'm sure many of us have seen patients who walk even right up next to death, such as dementia patients who walk in the hallways. In the self-care column, occasional assistance means that most of the time patients are able to transfer out of bed, walk, wash, toilet, or eat by their own means, but on occasion, maybe once a day or a couple of times weekly, they require minor assistance. Considerable assistance means that regularly, every day, the patient needs help, usually by one person, to do the activities referenced. Mainly assistance is a further extension of considerable, and of course, total care means that the patient is completely unable to do anything, eating, toileting, etc., or any self-care independently. Depending on their clinical situation, however, the patient may or may not be able to chew or swallow food once it's prepared and then fed to him or her. In the intake section, changes in intake are quite obvious, with normal intake referring to a person's usual eating habits while healthy. Reduced means any reduction from that and is highly variable according to that unique individual circumstance. Minimal, however, refers to very, very, very small amounts, usually pureed or liquid, which are well below nutritional sustenance. The last column, which is the level of consciousness, full consciousness implies full alertness, orientation with good cognitive abilities. Confusion is used to denote presence of either delirium or dementia and is reduced level of consciousness. Drowsiness implies either fatigue, drug side effects, delirium, or closeness to death, and may sometimes include the term stupor. And coma, finally, in this context, is the absence of response to verbal and physical stimuli. Some reflexes may or may not remain. An important thing I want to draw to your attention, if you're not familiar with using the PPS, is that you cannot choose between levels. PPS is a score that is done in 10% increments only. So sometimes there might be several columns that are easily placed, but 1 or 2 which seem to be better at either a higher or lower level. So you need to make a best fit decision. Choosing a half fit value of 45, for example, is never correct. The combination of your clinical judgment and leftward precedence is going to determine whether a 40% or 50% score is more accurate for that patient. So let's think again to that second example that we talked a few minutes ago about the patient who is paraplegic and bedbound, but still able to do some self-care, feed themselves. In that case, instead of 30, which is where we had originally placed that patient, the PPS might be higher at 30, 40 or 50% because the patient's not total care. The PPS is a really versatile tool and can be used for several purposes. And as we discussed in our introduction, one of the greatest utility is that it's an excellent communication tool for describing a patient's current functional level, because clinicians immediately have a picture in their mind of the functional status of that patient. Lastly, it appears it might have some prognostic value because at a super high level, a lot of teams would likely agree that scores of 50 or 40% are often indicative of patients who are hospice eligible. But then, of course, there are some caveats for cancer diagnoses, for example. So next slide, please. Early studies demonstrated that PPS scores could predict outcomes, and eventually even more studies showed that PPS scores were a strong predictor of survival. Steady decline in PPS scores is consistent with a decline towards death. PPS serves as the way for your interprofessional team to communicate with each other or with patients and families, as it can be used as a guide to help you initiate or facilitate conversations around goals for palliative care or appropriateness for end-of-life care transition. One thing that I think would be helpful for you is to consider thinking of the PPS, breaking the PPS into sort of 3 distinct stages, which can help your interdisciplinary team with planning interventions and what to focus on when you're having goals of care conversations. So for example, a PPS of 100 to 70%, patients in this category are generally healthy or at least stable. So at this time, your patient and family education is likely going to focus on disease management, symptom crisis or distress management plans, things like that. There may be referrals to optimize functions such as to PT, OT, things like that. When the patient's function declines to PPSs of 60 to 40%, this is really considered a transitional phase for a lot of patients, and it's incredibly difficult for patients and for families alike. At this point in a patient's decline, their illness impacts all spheres of their life, and so palliative care clinicians need to ensure holistic, patient and family-centered care. For patients and families alike, at this point, there are increasing care needs, educational needs, and a lot of times a need to coordinate care and services, including advanced care planning. The last section is when the PPS declines below 30%. Generally, we are considering this patient to be at the end of their life. Here, activities that the care team might want to do is to review medications, the need for or discontinuation of further investigations, lab tests, and clinic visits. Focus here is really on aggressive pain and symptom management and helping the family prepare for death, including ensuring that the patient's affairs are in order. Next slide. So at a high level, there are both pros and cons to using the PPS by your interdisciplinary team. One of the biggest benefits is that it is a way to track the decline of the patient, and it can be really helpful in helping to estimate prognosis, which obviously can help in care planning and helping patients and families to make tough end-of-life decisions. It really functions as an excellent communication tool, and it's a standard reference for healthcare providers, both between professions and across settings of care. A couple of drawbacks of using the PPS is that the performance status indicators may not be clear because they're based on an observer's recording, and different people might perceive a patient's ability to do things at a different level. And sometimes it's difficult to score between certain levels, like between 30 and 40% or between 80 and 90%. And of course, it's one other thing for your clinicians and your team members to have to complete. But to close out our conversation around the PPS, we think it's a great communication tool for quickly describing a person's current functional level. It allows for more common language around performance status than the Karnofsky performance scale from which it was based. And if you use this tool properly and consistently, it may help your care providers' recognition of who might benefit from aggressive symptom management, advanced care planning or care coordination, as well as to help drive appropriate management of advancing illness and functional decline. Last but not least, it helps facilitate communication around prognosis and goals of care with patients and families.
Thanks, Rory. That was really great. Actually learned a few little tips to take back to my team as well. But I wanted to talk specifically about symptom assessment and the use of the ESAS and the ESAS-r in that. So the ESAS, which is the Edmonton Symptom Assessment System, ESAS, I always like to know the backstory. So the backstory on this was actually created by Dr. Bruera, who came to Edmonton, Canada in 1984 to further his research for palliative care. He was a medical oncology fellow in Buenos Aires, and he saw firsthand the huge need for palliative care there, but it was lacking, and there was limited information in the management of symptoms such as pain, cachexia, dyspnea, psychosocial issues, and family support. So when he came to Canada during that whole tenure, he was able to bring palliative care to over 80% of the cancer patients who died in that region, which is amazing. Fun fact, Eduardo Bruera, Dr. Bruera, moved to Houston in 1999, Houston, Texas, to establish a palliative care program at MD Anderson Cancer Center. And he remains there today. He is dedicated to the cause of promoting the advancement of palliative care, and he's very active on LinkedIn and Twitter, and full of educational information that he shares. Next slide, please. So since its development in 1991, ESAS became a well-validated tool for simple and rapid documentation of multiple patient-reported symptoms. Multiple studies confirmed the validity of the assessment. It has been translated in over 20 languages and adopted in many clinical practice sites and research centers worldwide. Several studies, though, examine how patients perceive the ESAS and ways to improve the assessment. Many patients reported that they had difficulty understanding some of the terms, including depression, anxiety, appetite, and well-being. Others found it challenging to distinguish between tiredness and drowsiness. These findings led to a revised ESAS numeric rating scale consisting of the 9 core symptoms, which are pain, tiredness, nausea, depression, anxious, drowsiness, appetite, feeling of well-being, and even an optional 10th symptom. It stated the time frame of the assessment as now and added brief explanations for tiredness, which is lack of energy, drowsiness, which is feeling sleepy, depression, feeling sad, anxiety, feeling nervous, and well-being. How do you feel overall? It also changed appetite to lack of appetite, because that was another confusing thing in the original, adjusted the order of symptoms and removed some of the graphics, the horizontal line over the numbers, added some shading for alternative lines in gray for readability, and suggested constipation as the 10th item. So you can go to the next slide. So these are examples of the two. The first is the ESAS original version and the ESAS-r. So you can see some of the differences and similarities. Also on the ESAS-r, on the back or the second page, there is a visual where the patient can point to more specific pain or symptom points. You can go to the next slide. So these are just some quick facts and tips I came across when researching the ESAS. So what is it? It's a tool to help assess 9 common symptoms in palliative patients. Why? The goal is to find the patient's perspective of symptoms to help direct treatment and assess for treatment side effects. How do you do it? You instruct patients to rate symptom severity on a 0 to 10 scale on how they feel now, best possible to worst possible. It's always helpful to go over this in person, in depth the first time, because patients can get confused on how, it is simple, but still encouragement and education is best. When do you do it? Complete it at the initial encounter and during each follow-up or personal contact, where any setting, this is what's great about it, you can use it in any setting where palliative care patients are assessed and cared for. And then who should do it? Well, it's best for patients to complete it if able, or with caregiver input. If they are unable, caregivers can complete the scale with some objective clues, which I've added here, to teach the caregiver how do you see pain objectively? You're looking for grimacing, guarding, tiredness, maybe their increased amount of time resting is more drowsiness, decreased level of alertness, nausea, retching or vomiting, appetite, the quantity of food that they're taking in, shortness of breath if they're just have a really high respiratory rate or visibly distressed, depression, any tearfulness, being withdrawn, irritability, and even change in sleep pattern, anxiety, which can include agitation and restlessness, and well-being, just how the patient appears overall. Next slide, please. So some of the strengths and the weaknesses, as you can see, I'm an ESAS fan, so the strengths outweigh the weaknesses. But some of the strengths are it's quick. It can be completed rapidly in less than a minute. It's diverse, so it's patient-centered and translated and available in over 20 languages. It's measurable, so it's easy to administer and interpret and report. Flexible, it can be completed by the patient, caregiver, or with caregiver assist in many different care settings. It is valid. Multiple studies have proven validity, and it has widespread acceptance. And it's simple, so it's easy to implement in most EMRs, and it has some type of data graphing ability. So having ability to add this to an EMR, it is in many EMRs, but since it's a simple scale, usually if you can find the correct person in your EMR system, it's easy to add and start graphing. But if not, it's still available in paper format and using manual graphs to help identify trends over time. Some of the weaknesses, it does assess only symptom intensity, so it can be one-dimensional from that aspect. Few validation studies in non-cancer patients, but many people use it in seriously ill for measurement. I personally like to use it for focusing on one or two things that patients are dealing with at the time, because most of these seriously ill patients do have multiple symptom burdens. So it kind of helps you categorize where our focus is today and then work towards those goals. Some of the items such as well-being are not well defined, and there are different versions of ESAS with different time anchors and number of items. So sometimes in different systems, they can be hard to compare. Next slide, please. And then I just added about the permissions. The ESAS-r is freely available to use with appropriate acknowledgement of its source. I put the website where I gathered this information from and the references. It's a great website. It really goes in depth specifically on how to use and has a lot of really beneficial information. So I'll pass it on to Bob.
Hello, everybody. So moving into the FAST score, the functional assessment staging tool, this is one that I think many of us are familiar with. We use it frequently in palliative care and hospice. The problem with it is it really has been designed for diagnosis of Alzheimer's. So that is the key to this specific tool. We tend to use it for all dementias, but it really was designed specifically for Alzheimer's disease. So when you look at the stages 1 through 7, they are designed this way specifically to the progression of the Alzheimer's disease. So if you don't have a patient with Alzheimer's disease, they may tend to show skipping of stages, and that's not how this tool is designed. So you need to really make sure you understand that. It is a valid and reliable tool for Alzheimer's disease. And if the patient does have Alzheimer's disease, the staging, the progression of disease should follow exactly to this scale. And it really is showing the functional decline based on the cognitive inability, right? So as the individual's Alzheimer's disease progresses, their functional abilities start to wane away as well. So with an Alzheimer's disease, you would never skip a stage. So you wouldn't have somebody that could, maybe they're sitting at a 4, right? Sort of mild dementia. they can still kind of engage in their daily stuff, putting their clothes on and picking up their clothes, but they may not be able to do something like bathing themselves. That would not be a true, you wouldn't skip 5 to go to 6 in that situation. So one of the ways that I've used the FAST score to kind of still use it as with other dementias, right? There's many dementias that we're dealing with, and they all progress in a very different way. There aren't really good tools to help us understand how that cognitive deficit is impacting their functional ability and their overall decline as they progress with their disease. One of the ways that, and I've been successful with this, and even through things like ADRs, additional documentation requests, and things of that nature, is looking at these stages at a year, 6 months, and today. So having the family or the patient, if obviously the patient is maybe in the 4s, 5s, they may still be able to participate in verbalizing their own capacities here. But if you start looking at dementias, what were they doing a year ago? What were they doing 6 months ago? And what are they doing today? You can start building a trend line that may be very supportive in how you're looking at that patient. Because again, this tool really has been designed for the Alzheimer's patient. So other dementias, it may be a way of thinking about how do you use this tool to support your documentation as you think about where that patient is in their progression. We tend to get this wrong a lot on the hospice side because we skip stages. If somebody is not incontinent of urine or feces, but they can't really speak very well, that does not mean they're a 7, right? They're still a 6 or probably a 6D or a 6C. So just be very aware of that. That's probably the one limitation of this tool. It's a great tool. I think it has a lot of benefit for how we can think about patients with dementias, but realize that it really is meant for an Alzheimer's patient, and it is meant not to skip. Rory talked about the PPS, very similar thought pattern, right? So a lot of the things that how she illustrated the PPS, this is the same way. 1, 2, 3, 4, 5, 6, 7 progression. Next. It's fine. You can go to the next one, Bernice. So thinking still with cognition, the cognitive ability or our ability to really assess cognition is a bit fragmented. Probably most of us are familiar with the brief inventory or interview of the mental status, the BIMS. This is one that is used in nursing homes as part of the minimum data set. It is mandated by CMS to be used in all skilled nursing facilities. So we run across it often. It's very easy to use. It takes 5-10 minutes to do it. It's multiple subscales or tests that are within it, and you can quickly get an idea of capacity for that patient. Scores less than 13 would indicate that there are cognitive issues there. The 13, 14, 15, the higher the number there goes. So if they're under 13, that they should still have capacity to make their own decisions. So these types of tools and these scales that we use, we have to think about them from a specificity perspective as well as a sensitivity perspective. The BIMS is not overly specific because it's really meant as an assessment tool. So some are diagnostically focused, some are assessment focused. So for what we do from like on a hospice side, we're really just assessing the capacity of an individual. Do they seem to have capacity to make their own decisions? Are they moving more into that gray zone, 12, 13, 14? And the BIMS is a really good tool to use. The general practitioner assessment there on the bottom, this is one that I hadn't really thought about a lot. I haven't used it, but in looking at it, it seems like a tool that would be very beneficial both on the palliative side as well as the hospice side, because it's more specific and it's more it has more sensitivity to it, and the practitioner can utilize it very quickly. So it's designed for general practitioners to use as an assessment tool. Again, it's not necessarily a diagnostic test, but it's a little more specific and sensitive to where the cognition of that individual is. So it could be a good tool to use for us in these settings. The other ones, they're all a little different. The reality comprehension clock is really a secondary tool for the BIMS. So if that patient that scores 13 or a 99, 99 is really not very good, it could be another tool to become a little more specific on what's going on with that patient. Let me see what I had written here. Yeah, that's probably pretty much it. The BCAT is unique in that there are 6 assessment instruments, if you want to look at it that way. There's the full instrument, which encompasses all of them, or you can break them down into various categories. So the full version has everything. There's a short version, which has everything, but obviously a shorter way of looking at things. Then there's one that specific to mood impairment. There's one that's practical judgment. So that's a visual test. There's a nuance and subtle judgment test, and then there's a cognitive functioning test. So depending on what practitioner or an individual may be looking at, the BCAT could be an interesting tool to use, because you could use part of it to get a more narrow view of what's going on with that patient. So all of these tests are valid. Many of them haven't been tested in multiple settings. The BIMS, the brief interview of mental status, has really been studied primarily in nursing homes. So although it is a valid tool, it has much research behind it, it really hasn't been validated outside of a nursing home setting. Doesn't mean it doesn't work. It doesn't mean it can't be supportive of what you're trying to accomplish. All of these have been similar. The other one that is interesting is with the general practitioner assessment. There are multiple language versions of that one. So depending on your patient population, because many of us live in areas that have high volumes of patients that speak different dialects, right? So that's a good test that has a lot of different language versions that could be utilized. I think that's it for me, Bernice.
Thanks, Bob. This is Christine. So we all probably agree it's very challenging to differentiate between normal and appropriate reaction to serious illness versus a treatable major depression. The symptoms that we manage and see with our patients, symptoms associated with depression that our colleagues in the primary care setting are seeing, things such as weight loss, loss of energy, fatigue, insomnia. These all also occur in our patient population that don't have depression. And so we can see how it becomes important to really think about what are a standardized screening process to capture and diagnose depression and anxiety. So I want to walk you through a little bit of an idea of tools that we would recommend to consider in your practice and to recommend to your colleagues, particularly those in the primary care setting, what they would find very helpful. Next slide, please. So routine screening really helps identify those patients at greatest risk. Depression, and when you look at our literature, is really an independent predictor of mortality. We know patients, it impairs their quality of life, it can cause non-adherence. So it's very important that we diagnose this sooner and earlier to be able to provide treatment. There are several brief screening instruments used to identify depression in our patients, and that's why it can be tricky on what's a great tool to use. Next slide, please. And so it is important that any clinician, any of us that are caring for our patients, again, I always bring up our colleagues in the primary care setting, that our patients with a serious illness, that there's conducting of regular screening for mental health issues, particularly with depression and anxiety. Again, when it's identified earlier, we can treat it successfully and help get it treatment more under control sooner. Next slide, please. There are a collection of tools to assist with clinicians in assessment of the psychological and social impact of the serious illness on our patients. Again, overall, there's little evidence of one tool recommended over another. Screening is very useful when there is a workflow or a response to a positive screening, when there's a treatment plan in place. Those are really ideal settings to think about when you're doing a screening tool. We recommend the following tools to be used: the PHQ-4, the PHQ-9, and the GAD-7, which many of us may or may not be using currently in our current practice. So I'll walk you through those. Next slide, please. Thank you. The PHQ-4 is a great screening tool. When you look at it, it's easy to administer. It can be done inpatient or outpatient. It's really 4 questions. And a score of 3 or greater is considered a positive for screening purposes. If you have a patient that captures an elevated PHQ-4, again, it's not diagnostic, but it's an indicator that you want to do further inquiry to establish the presence of depression, for example. That's when we would recommend to do further evaluation using a PHQ-9, which we'll talk about our next slide, please. The PHQ-9, again, is a wonderful tool, and it can be done in any kind of busy practice, whether inpatient or outpatient setting. The PHQ-9 identifies those patients that are at highest risk. It's usually, ordinarily, a score greater or equal to 10 indicates likely a depression in a general population. However, there's been suggested research that in our patients with serious illnesses, we should have a lower threshold. A PHQ-9 score of above 6 should be considered depression and would recommend for treatment. This is a great tool because this will help track your response to treatment over time. So this is a tool that you will use again in reevaluating and a follow-up with your patient in regards to how they're doing responding to treatment, for example. This does come in different languages, Spanish language, for example. So there is availability in different languages. Again, it can be administered verbally by a staff member if you have a designated staff member. And of course, self-administered by the patient themselves would be ideal. But this has been looked at different settings, as well as the response to treatment and a follow-up visits to be used again over time. Next slide, please. And finally, a tool that we recommend to consider is the Generalized Anxiety Disorder 7, the GAD-7. Again, this is a tool that can be used easily in an inpatient or outpatient setting. We know and recognize that anxiety is very common in those patients of ours facing these life-threatening illnesses and disease comorbidities. There was a study that actually recognized that 50% of patients with heart failure and COPD actually experience significant anxiety. So again, we really want to capture, do regular screening on our patients. And this is a great, easy tool to administer to be used in any setting. When we look at this instrument, it does have a validated diagnostic tool. It does have a Likert score. So if you look at the score themselves, a score of 10 or more is, again, has good diagnostic sensitivity and specificity, correlating with a significant anxiety that your patient would be referred or would be recommended to initiate treatment for your patient. Again, it's something that can be used to continue to monitor your patient with, and it can be used again in the primary care setting for your colleagues. If you want to have a recommendation of a tool for them to use, this is a great tool that has been validated and to help in the outpatient setting as well. Thank you. Next slide.
All right. So in summary, just a few reminders, and you can just click through these. First of all, these tools are available online, so make sure that you're always looking for the latest version. These tools are often updated and perfected through time and lessons learned, so you want to make sure you have the most recent version. As you heard several of our presenters mention, pull in your EHR folks. Sometimes various platforms have options to pull these tools directly into your documentation assessments. So for ease of documentation and saving time, that's a great option. A recommendation is to make sure you're spending time as a team really reviewing these tools. Results get muddied for sure when there is not enough time spent on the front end talking about how to interpret the questions asked, how you complete it, how you streamline those interpretations. So how the tool is used by your team and having some standardized approach is really important. Remember, these tools are a snapshot in time, one data point. It is one piece of the story. And as we've mentioned, these are tools, and tools are used to accomplish something. They are a means to an end. So they should be a guide for action. Next slide. So why this is important? First of all, to our profession. These evidence-based tools are important to our profession as palliative care specialists. They provide a standard means of assessment and evaluation, which then allows us to reassess again in a standard way so we can see if what we are doing is impactful. I love that these tools reviewed here are truly holistic and interdisciplinary. This demonstrates care for the whole person, body, mind, and spirit. It provides us a way to create truly individualized care plans. We pride ourselves in ensuring that our care is patient-specific, patient-centered, and these variety of tools provide us with a means to narrow down our focus on areas of concern. It demonstrates the interrelatedness of our patients' symptoms. For example, we can demonstrate that reduction in pain increases sense of well-being, reduces anxiety, alleviates depression. It creates an opportunity to influence our QAPI plans. I know in our program, we're really focusing on pain improved from our first to last intervention when a patient is inpatient. We've looked at anxiety through the years. So we can make sure that what we are doing, again, is truly impactful. Why is it important to our referral sources? Well, if these tools are used right, explained properly, it can equip our care partners, our referral sources, our PCPs, with tools that can indicate if palliative would be helpful. Earlier, more timely referral to palliative care and hospice. How many of you have used that surprise question, right? That kind of very subjective, would you be surprised if the patient was still with us in a year? This is much more concrete. And we know that many of the providers we work with are not the greatest prognosticators. So this levels that playing field and is a way also for you to get in front of them and to really advocate for our profession. Next slide. These tools are important to our health systems. If you are part of a health system, you certainly know that we are working hard on that necessary shift from fee-for-service to value-based care. And if there's one thing we know for certain is that we know both palliative care and timely hospice care services are key in this. We are not maybe revenue generating per se, but we are programs that greatly reduce cost for patients with serious life-limiting illness and multiple chronic conditions. We know that our interdisciplinary team approach cares for the whole person, addresses social determinants, and that these tools are tools that can help identify patients sooner, help us measure the impact of our interventions, and provide our system partners with a means of identifying patients in need of our services. And we know that timely care can really impact those very critical system initiatives, such as reducing mortality rates, cutting down ED visits, reducing readmissions, and these things matter to our system. These tools can be means of not only identifying patients earlier, but demonstrate that reduction in symptom burden and timely referral helps impact these critical symptom metrics. And mostly, these tools are important to our patients. I don't want to belabor this point, but these tools help create individualized, holistic assessment plans of care and provide us with indications that palliative care and potential hospice can be beneficial. And with earlier identification, we can ensure right care for the right patient at the right time. Next slide. That is something I think that is just core in our hospice and palliative care, in making sure that we understand what's most important to patients, what their struggles are, and then aligning that care that is critical to support them at that time. So the right care for the right patient at the right time. And lastly, next slide. These tools are important in achieving the quadruple aim. And again, I've kind of talked about this, but utilizing these tools from a professional standpoint and a patient-centered perspective can help improve population health as we move to quicker, more timely referral for patients who need our hospice and palliative services. It helps reduce costs for that same reason. It ensures that our care aligns directly and further upstream with what the patient really wants. It increases provider satisfaction as it provides evidence-based tools they can use proactively and then refer to palliative care to partner with them in caring for their most complex patients. And it increases patient satisfaction by sorting out what is most troublesome for patients, what their hopes and fears are, and then aligning the right care for that right patient at the right time. So total win for palliative care, for our teams we partner with, for our health systems that we support, and ultimately, and most importantly, the patient. If you can scroll through the next couple of slides, I think there are reference slides. I just want to get to that last slide that again shows all of our contact information. I want to thank all of you for attending this session. As a reminder, we are all here, our names, our organizations, and feel free to contact any of us. I can speak for all of us that we are more than willing to address your questions and hear your concerns. And please keep the conversation going in the discussion group of this session that is located, the when and where of that is on the conference website. But definitely reach out to any of us with questions. I want to thank my esteemed colleagues for your great presentation. I learned some things, so I want to thank you so much for that. And thank you to all of you for being such an attentive audience.